Good morning, everyone. Today, the topic for discussion is acute inversion of uterus. This is a rare complication usually seen when the third stage of labor is mismanaged. Coming to its definition, it is when the uterus turns inside out. It's called as uterine inversion, and the inversion of the uterus may be partial or complete. Uterine inversion is the folding of the fundus into the uterine cavity, and it is usually of varying degrees. And the inversion of the uterus is classified into three according to the types, according to the degree of inversion, and according to the time of the event when inversion occurs. The types of inversion of the uterus. When the incomplete inversion, it is when the fundus of the uterus has turned inside out, but the inverted fundus has not descended through the cervix, that is, it is within the cervix. Complete inversion, when the inverted fundus has passed completely through the cervix and it may lie within the vagina or may lie outside the vaginal wall. This is the complete inversion. Based on the severity of the uterine inversion, there are 3 degrees. The first degree, the fundus of the uterus is just depressed. That is, there can be dimpling or cupping at the level of the fundus of uterus. Second degree, the inverted uterus protrudes through the cervix, but it is within. In the third degree, the whole uterus, including the cervix, is inverted, and this may drag the vagina, and it usually appears outside the vulva. Here in the first picture you can see here the inverted the fundus, just it's like a dimpling or cupping which is seen. Coming to the second degree, here the body of the uterus through the cervix, just it protrudes outside, but it is not outside the vulva. Here the complete uterus, even along with the cervix, it protrudes outside the vulva. This is the one more picture where the along with the placental attachment you can see cord. This is the first degree where the fundal insertion of the placenta is there along with the just dimpling of the fundus of the uterus. In this, the uterus has inverted and it protrudes through the cervix. Here it completely descends outside through the cervix and appears outside the vulva. The one more classification, it is based on the timing of the event when this uterine inversion occurs. Acute is usually it occurs within 24 hours of delivery. Subacute occurs after 24 hours but within 4 weeks following delivery. Third is a chronic, it occurs after 4 weeks of delivery. Maximum inversions what we see are usually acute inversions and they are complete inversions. Acute inversions occur immediately after delivery, either normal delivery or cesarean, and they should be managed immediately. And they usually occur when the third stage of labor is mismanaged. And the common causes which we see is, most common cause of this uterine inversion is puerperal inversion. It is because of mismanaged third stage of labor. At the time of the placental delivery, if excess cord traction is given along with the fundal pressure on a relaxed uterus, you can see the uterine inversion. The risk factors usually we see are the fundal insertion of the placenta could be a cause, morbidly adherent placenta such as placenta accreta, and the short cord, and use of uterine relaxants for manual removal of the placenta. It could be either spontaneous or iatrogenic uterine inversion. Usually the inversion of the uterus is commonly occurs at the time of cesarean section, and it is easily correctable. And major degree of uterine inversion is rare during cesarean, and if not diagnosed immediately, it could result in hemorrhage and the shock. So immediate identification or diagnosis and immediate correction of the uterine inversion, reverting back the uterus to its normal position, is important. Otherwise, it results in hemorrhage and shock. So there is a standard recommendation that placenta should not be delivered before correcting the inversion of the uterus. But at times this may not hold true in case of cesarean, because the bulk of the uterus and the placenta may prevent in reducing the uterus through the incision. So if half of the placenta has separated, you can remove the rest of the placenta and try for correcting the uterus. And oxytocin should be promptly given after the inversion is corrected, so that you can prevent the reinversion of uterus. In the pathophysiology, when a portion of the uterine wall prolapses through the dilated cervix or it indents forward, then subsequent relaxation of the uterine wall results in simultaneous downward traction on the fundus, which leads to the inversion of the uterus to protrude it outside the vulva. It appears outside vulva. Diagnosis. Usually there is a classic triad of symptoms which we see. It could be hemorrhage, shock, as well as severe pelvic pain. The shock usually we see is a neurogenic shock here, and the shock is due to the traction on the ligaments which support the uterus, and it causes parasympathetic stimulation, that is neurogenic, or it could be hypovolemia. Hypovolemia is because of the acute blood loss which occurs. Usually it is better to arrive at the diagnosis clinically, first by palpating the uterine fundus and note any cupping or dimpling is there, or irregularity of the surface counter of the uterus. In severe cases, if its uterine inversion is complete, in such case per abdomen uterus is not palpated. Abdominal palpation is not enough because abdominal sign of cupping may not be obvious all the time. Bimanual examination should be done to appreciate the cupping or the missing fundus. And the diagnosis we made if the fundus is routinely diagnosis can be easily made when in the third stage of labor, if you palpate the fundus of the uterus and see if the uterus is contracted or not, so that you can appreciate and feel the fundus of the uterus in such cases, And vaginally, if it is a complete inversion, then you can see a fleshy red mass outside the vulva in case of third degree inversion. Coming to prevention, it can be prevented when the delivery is conducted by skilled birth attendants, and the correct management of third stage of labor should be done. An early diagnosis of the uterine inversion and immediate repositioning without placenta removal if attached. These are important to reduce the associated morbidity and mortality associated with uterine inversion. Coming to the management, immediate resuscitation of the patient is very important. Immediate replacement without attempting to remove the placenta from the uterine fundus should be done. Initially, we should try like that. Moreover, removing the placenta from the inverted uterus, it increases the risk of injury to the uterine wall, which can be easily torn and get perforated. In the case of immediate resuscitation, you should make sure 2 large IV bore cannulas are secured, and IV fluids should be static crystalloids, and blood and the blood products should be cross-matched and kept ready. And you should ask for help if required. There are only 2 indications for removing the placenta before replacing the uterus. The first is when a portion of the placenta is separated. then it is easy to remove the rest of placenta. And second, during cesarean, when there is a difficulty in reducing the bulk of the uterus through the incision. So in many cases, acute inversion occurs in absence of skilled assistance usually. In such cases, if immediate identification and correction of the uterine inversion is not done, it results in the patient becoming unstable and ultimately to shock. So in these cases where it's not possible to correct the uterine inversion immediately, first thing you can do is to convert a third degree inversion to a second degree uterine inversion by raising the foot end of the bed to maintain the inverted uterine mass within the vagina instead of it hanging outside. So this reduces the shock as well as the risk of infections. And if the patient is already in shock, if you are trying to replace the uterus back to its normal position in the presence of the shock, it may prove to be fatal. So in such cases, first you need to correct the shock, and then after the patient becomes stable, then you should go ahead with correcting the uterine inversion. So if required, the patient in case move to the operating theatre and a broad spectrum antibiotics should be given. Uterine tocolytics can be administered before correction by giving glyceryl trinitrate 600 micrograms sublingual or terbutaline 250 micrograms subcutaneously. If adequate relaxation is not achieved, then you can go ahead with general anesthesia with halothane or sevoflurane. This usually causes a dose-dependent depression of the myometrial contractility, and so it facilitates the rapid reposition of the uterus. Just coming to just basic, as uterine inversion, once it occurs, first immediate resuscitation should be done, that is by securing 2 large bore IV cannulas, fluids or bolus replacement, and the blood and the blood products, if required, they should be arranged simultaneously, and immediate replacement should be done. If the uterus is replaced, then remove the placenta and oxytocin infusion should be given. Accordingly, antibiotics should be started. If the uterus is not replaced, then under general anesthesia and stabilization of the patient should be done, followed by manual reduction of the uterus by applying the pressure to the dependent part of the uterus and simultaneously the other hand abdomen. And if this also fails, then you'll go ahead with O'Sullivan's hydrostatic method. In this dependent part, you should replace into the vagina by giving 5 liters or more of physiological solution which is deposited into the posterior fornix, and by making a water seal tight near the vagina. Initially, conservative methods should be tried. If they fail, then only we are going to go ahead with surgical intervention. And the conservative methods are manual replacement of the uterus and the hydrostatic reduction. Coming to the manual reduction. In the manual reduction, the part which has inverted last should be reduced first. In other words, it is the part near the cervix should be repositioned first rather than the inverted fundus, and trying to push the extra thickness of the uterine wall later through the cervical ring. Then if it is successful, the hand should be kept within the uterine cavity and oxytocin should be administered until the uterus is contracted. In this you can see in the manual reduction, either grasp the prominent part of the uterus which is outside the vagina, or by making a fist, hold it, and then through the cervix you are going to put it to its normal position by the direction towards, and the other hand should be on the abdomen to guide that you are placing it in the proper position. And after correcting, the hand shouldn't be removed immediately. You should make oxytocin should be administered and make sure that the uterus is getting contracted. Once the uterus gets contracted, then the slow removal of the hand should be done. If the manual reduction of the uterus fails, then hydrostatic reduction, it's also called as O'Sullivan's technique. In the manual reduction fails, the correction of the vagina is tried by infusing the warm saline into vagina. Prior performing this procedure, you should make sure that the uterine rupture has not occurred and the patient is kept in Trendelenburg's position to assist gravity and reduce the traction on the infundibulopelvic ligaments. So 2 bags of usually 1 liter of warm saline are placed at a height of 1 meter above the patient and connected by wide tubing. And the tube is placed near the posterior fornix with the hand in the vagina. So it usually watertight seat should be kept at the vaginal introitus by approximating the labia majora. Shilpa. Alternatively, a 6 cm or elastic ventouse cup can be also used to seal the vagina and infuse the saline. See, these are the Silastic vacuum cups which can be used. And you're infusing the warm saline for correcting the inversion of the uterus. If the above conservating methods fail, then we go ahead with the surgical procedures. In this, repositioning of the uterus is done by laparotomy. It could be via vaginal route or abdominal. Coming to the abdominal procedures, first is the Huntington's method. In this, after opening the abdomen by laparotomy, locate the cup of the inversion where it is there and identification of the round ligament should be done. Then Alice or Babcock's, they are applied on the myometrium or the round ligaments in the cup. This is 2 centimeters below the ring, below the inversion below the cup of inversion which we see, and gentle upward traction is given. Later again new clamps are applied 2 centimeters below the previous clamp, and we are going to repeat this procedure until complete replacement of the uterus occurs. An assistant also facilitates by simultaneously pushing the fundus upwards from the vagina. If this fails, later is the Holtein's method. In the Holtein's method, if the cervical ring is tight and the uterine fundus cannot be pulled through it, through clamps what we are using, then the size of the ring can be increased by giving an incision posteriorly on the uterine wall over the ring. If the incision is given posteriorly in this procedure, it is called as Holtein's. And if anteriorly we give the incision and go ahead for correcting the uterine inversion, it is Osijos method. And later the hysterotomy site is repaired, the closure is done. Usually posterior incision is preferred because accidental injury to the bladder can be avoided. Coming to the vaginal procedures, that is Spinelli's method. In this vaginal approach, initially the bladder is dissected upwards and it is pushed up. Later the ring and the lower part of the inverted fundus, that is the part which lies near to the cervix, it is divided anteriorly and then inversion is corrected. Following it, the incision is closed. In the vaginal procedure, that is Kastner's method, here the cervical ring is divided posteriorly. In Spinelli's, it is divided anteriorly. In Kastner's, it is divided posteriorly. In cases where the uterus is gangrenous, the best is to proceed to hysterectomy after correction of the uterus. And the complications most commonly we see are maternal death which occurs, it could be because of hypovolemia, that's blood loss, or the neurogenic shock. If untreated, it can cause infection, uterine sloughing, or chronic inversion. After treating the inversion of the uterus, there is a risk of placenta accreta in subsequent pregnancy, or postpartum hemorrhage can also occur. So to avoid this, third stage of labor should be correctly managed by skilled birth attendants. Thank you.